Thank you for having me, and great to be here. So I'm just going to give an example of some work that we did at Moorfields based on what the both profs have said, and try my best to follow this lovely presentation. So we did some research looking at underserved communities, and for us, Moorfields, we had our big eye hospital in the middle of London. We've got 21 network sites. So we did this study recently, and we asked our patients, how important is your sight? And most people said that sight was their most important sense. Another study in America in 2016, they asked individuals, which condition, so out of blindness, cancer, HIV/AIDS, Alzheimer's, which one is the worst thing that can happen to you? And most patients said blindness because they feared the loss of their independence. So back to the definition about the underserved community. So it's there, the NIHR has said that the underserved community is a group that's less well represented in research that would be desirable from population prevalence and healthcare burden. So this is the definition that we went with. And then, funded by the North Thames Clinical Research Network, we devised some strategies to look at promoting community engagement and accessibility in our underserved community. So back in 2018, I was doing a Florence Nightingale Fellowship, and this has always been on my mind. And the title is BAME there on purpose, because at that time, the BAME acronym was accepted. So the campaign was called I Care, Be Aware, and we had Dame Ruth May at our program launch. And then we had third sector parties, charity partners come together to think, what can we do to attract this population into research and also to promote eye healthcare in these communities? So we did focus groups, as we do. We are researchers. We found that over 2/3 of our patients at our central site in London self-identified as being from a minority ethnic group or global majority background. And we know the different risks for different diseases in that population. But in terms of eye diseases, the African-Caribbean population had a 4 times more chance of developing glaucoma. The Asian population was also at a higher risk. And then that's compounded by diabetes, which is also higher risk in both populations. So when we speak to our community, they told us about several things. First was decreased awareness. So these individuals didn't know the importance of eye care. I'll give you an example. At our Zoom sessions or in-person sessions, we said to them, how would you wash your eyes? Explain to me how you wash your eyes. And over 2/3 of them said that they would put soap and water on their open eyeballs to wash their eyes. I can give you lots of other examples. I'll give you one now, actually. There's a drop that's been approved by different religious leaders in different countries, and it's a cure-all, especially for cataracts. So they advise that you put a drop of lemon, a drop of honey, and a drop of onion juice into your eyes every day to cure cataracts. So moving on swiftly. We also had decreased attendance and late presentation to different eye appointments. We mentioned this before, socioeconomic restrictions. So most of our patients were saying, I'm not going to the opticians because they'll force me to buy glasses, not realizing that the opticians are literally the GPs for your eye health, and they're able to diagnose early conditions like glaucoma before any other healthcare professionals, and not mixing up your diabetes eye screening with your opticians because it's two totally different appointments. Another issue that we've heard before is language barriers. So we know in our clinics how much of our literature is not exactly translated into different languages, and then providing care to these patients without translation. So we do lots of injections at Moorfields. Lots of conditions require injections. And having a treatment for a condition, other parts of your body, with an injection, fair enough. But imagine someone coming to your eyes without telling you why they're coming to put an injection in your eyes. I don't think any of us would actually accept that. And then I've also personally seen, I went to an Asian corner shop to get my hair done, and I saw a patient had just left the hospital across the road and went to the clerk and gave the clerk his outpatient appointment letter, and the clerk was translating to him what his treatment, long-term management was, what his diagnosis was, what medication he had to take. Now, how many red flags does that raise for us as healthcare professionals? Why did he have to leave his healthcare provider to go to the clerk to get that done? We need to change that. Religious beliefs. There are lots of beliefs. God will heal me. I don't believe in Western medicine. I personally have had a few slippers chucked at my head when I went to recruit patients from different communities because I was a sellout. I was with the white man. And it's all about engaging, conversation, building that trust, explaining. And what happened in that situation was, it was around 2009, 2010, when the Metropolitan Police in London had just introduced this DNA database for criminals. And this elderly Afro-Caribbean lady, she didn't want to give me her blood sample because she was afraid that given the hospital her blood sample, the police will be able to trace via DNA her nefarious young grandson who was involved in different activities. Who would have ever made that connection? But literally, we had to explain to her that this data is siloed within the hospital. It doesn't go anywhere. The police definitely hasn't got any link to this. So again, it's building trust and explaining. Societal stigma. So this is present for for different communities, but particularly in ethnic minority communities, global majority communities. We are frequently seen as being flawed. We had this example in one of our focus groups. This individual from a Pakistani background, and she explained that within her family, her eldest sister lost her sight at age 5 due to a condition called retinitis pigmentosa. Now, the mum knew she was blind, the dad knew she was blind, but they refused to tell any of your family members because that will affect this girl's chance of getting married later on. So therefore, her other younger sisters, the middle sister and the youngest sister, were only picked up for treatment by the social worker because the eldest child had a vision test at age 5 when she went to school. And she recalled going to different community events, so weddings and parties, where people will say, there go the 3 blind mice. Fast forward a few years, she mentioned she'd gotten married. Well, first of all, she went to a consultant, I wouldn't name the hospital, and said, my family wants me to get married to my cousin in Pakistan. What do I do? Will it affect my children's condition, eye condition? And the consultant then said to her, well, you might as well shoot yourself. Fast forward, gets worse. Fast forward a bit more, she mentioned that she did go to a family wedding, and those of us who go to these family weddings, you know that everybody is your auntie, your uncle, nenen, as you call them, and anybody can say anything to you because it's that community. And someone just came up to her, completely random person, you must have sinned in your previous lives, that's why you're burdened with this condition. And then, okay, fair enough, I look like you, tell me that, but then you turned to my white husband and said to him, you must have sinned also because you're burdened with this wife. So she was saying that, for years she actually hated her mother because her mum didn't protect her. But then now she realizes that the mum didn't have access to support herself because the husband said, don't tell anyone. The mum couldn't speak English. We need to support not just the patient, we need to look at families as well. So something else I've been championing lately. At the last UK CRF conference, we were shown this slide. 92% of studies in the UK biobank, so 92% of studies that take data from the UK biobank only use white European data. There's a problem with data. We don't have enough black data, Asian data in the system. But then something else, and this is what an example I used to tell my patients, definitely, we're talking on these Zoom calls. So we were also told that there's 117,000 gigs of white data every day in the NHS, but there's only 5,000 gigs. So think about having a credit card system. Those of us who have lived in deprived areas, you know that your postcode matters whether you get a credit card or not. Similarly with AI, if there isn't enough data for the system to train itself on, therefore personalized care will be a remote possibility. So what did we do about it? As we've said before, we go to the people. So we've done outreaches in churches, temples, mosques, hairdressers, barbershops, food banks, which is content appropriate and in the language that these people do speak. We dispel myths, so the onion juice, lemon juice, and honey. After I had, try to keep inside my disbelief at, why would you put onion juice in your eye? Never mind. Just to tell them, okay, this myth, yes, this is what this religious leader has recommended, but this is what it does to your eyes. Weigh up the benefits. You're the one suffering. Let's think about it. Different eye conditions. People would not go to their GPs. They would not go to the optician. So how do we give them the knowledge to be able to identify what conditions are important and how to treat those eye conditions? I'm talking about putting in your drops. We had a really important session. We went to Haitian Flag Day, and it was just a 5-minute intervention. This daughter came to us to say, my dad is really depressed. He's got end-stage glaucoma. He's only got tunnel vision. How do I help my dad? So we had the simulation glasses showing what glaucoma looks like, and it's literally no peripheral vision, just tunnel vision. And she began to cry because she's like, now I understand why my dad is so depressed. So then we were able to tell her about, okay, how do we put in his drops? How do we get in, more psychological support? And in the 5-minute intervention, we changed her and her family's life. Engaging with community leaders, we spoke about that before, and I'll start to skip. And here are just some sessions where we've got a black majority church and a Swaminarayan temple. And here in my team, again, at another event, just giving out leaflets and then doing some healthcare interventions and speaking to the young people as well, so then they can go and populate and tell their communities. So this patient, very important. So in a patient over the age of 50 or 60, that white line there, which I'm pointing to, is called a corneal arcus, and it's usually seen as age-related. However, this gentleman is 35 years old, and this relates to his high cholesterol. Now, this is an anecdotal story because we said to him, have you gone to your GP recently? He'd never been to his GP, never been to an optician's. Signposted him to his GP, and then he called us and said, my GP said I was 6 months away from having a heart attack. This is what he said to us. And he said, thank you for saving my life and my 2 young kids. So it's really important that we go to where these people are and speak to them in their language, content appropriate, and encourage them to access not just healthcare. And the reason we've put healthcare in there is because we need to tell them about what's important to them, and then they will tell us what we need to know. So we also developed this database called Rome. It won Nursing Time Awards back in 2021, where our patients are able to go online and transparently see what research we do at Moorfields and also join. And we've done some co-production work where we've translated our Rome leaflets into different languages. And here we've got Gujarati, Hindi, and Punjabi. So, based on all that work, we've been able to see over 5,000 people face-to-face, translated the adverts into 7 different languages. We've got lots of visits to our site. What I'm most proud of, though, we went on radio and spoke in English and Hindi, and we had over 42 million listeners talking about eye health and research. And for that work, we've got 5 national international awards, including achievements in eye and vision advocacy. So the message is, those patients, your voice matters. We need to listen to what they have to say to be able to and engage to get a better outcome for them and their communities. And this is a team I've worked with. Thank you very much.
Thanks, Roxanne. One question we have here is, what locations have you used for engagement with black communities and which have been most effective and why?
So every second Sunday we go and volunteer in black majority churches. So if you don't, the funny thing is, if you know someone, even if they're not religious, they also always know someone who is. And therefore the message passed on, as Professor Brown had mentioned. But the barbershop is always located next to a chicken shop. Great. Perfect location. And that has worked for us. So the churches, definitely, we speak to the pastors, we speak to the imams, we speak to in the Swaminarayan temples, so and that works for us, definitely. And always take along a researcher who looks like the population you're going to, because it's all well and good. I mean, my British accent is brilliant, but then if I go to the community, I switch back to my Trinidadian twang, and it's more accepted.
Thank you. That was fabulous. Thank you very much. The anecdotal comments you made were very, very pertinent, I think. This is a sort of general question. How are we going to stop clinicians making crass comments?
Interesting you should say that. So we've just put in a bid, and hopefully it's accepted, to the RHO tender for decolonising the curriculum. Because I don't think I'll give you my own personal example. I was born in Trinidad and Tobago, but I came here to do my training in University of Surrey, a predominantly white area. And I went for 3 years of training without seeing a single black patient or nursing a single black patient. Got married, went to Sheffield. I had my first black patient with prostate cancer, and I had to call my mum and say, "Mum, how do I know whether he's cold, whether he's sick?" Because I can't tell based on what I've learned, the different colors. So if you're hot, you're red. If you turn a bit green, you're feeling sick. If you turn a bit blue, you're cold. And that brought home to me that I didn't know how to look after my own people. So it's about decolonizing the curriculum and changing what we are learned in schools, but also with that, language matters and crossing those barriers. And there's a big document for diabetes in terms of language matters, and it's quite general, actually. I saw it yesterday. The advice in how to approach people can be addressed and can be applied to every community. It's just literally being humane. You wouldn't like I said about you, why should you say it about someone else? Why should you be that judgmental?
Thank you very much.